This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we will use the commercial name. Please note that the availability can vary between Australia and Aotearoa, New Zealand. Welcome to Talking ONG, a RANZCOG podcast. This is where we unpack the latest clinical guidance, research and practice updates shaping obstetrics and gynecology across Australia and Aotearoa, New Zealand. Today we are turning our focus to cervical screening, an essential pillar of cervical cancer prevention. Thanks to the success of Australia's national HPV vaccination and screening programs, we are on track to become the first country in the world to eliminate cervical cancer. To support clinicians in this mission, RANZCOG has released a new signposting guideline, Cervical Cancer Screening in Australia and Aotearoa, New Zealand. This episode unpacks what the signposting approach involves and explores key updates in Australia's cervical screening landscape. We'll look at how clinicians can apply this guidance in everyday practice, from managing complex scenarios to delivering equitable care to underscreened communities. I'm Dr. Nisha Khot. I'm an obstetrician gynecologist based in Melbourne and the president-elect of RANZCOG and your host today. Joining me today are two clinical experts, Dr. Anna Clare and Dr. Jared Watts. I'll get you both to introduce yourselves. Let's start with you, Anna.
Hi, I'm Anna Clare. I'm a specialist obstetrician and gynaecologist from Perth in Western Australia. I'm the Deputy Chair of the Women's Health Committee for Gynaecology, and colposcopy is a regular part of my clinical practice.
Hi, my name is Jared Watts and I'm the Director of Obstetrics and Gynaecology for the Country Health Service in Western Australia and Associate Professor at UWA. I have an interest in ways we can undertake cervical screening in rural and remote settings.
Welcome to you both. Before we begin, I'd like to invite each of you to declare any conflicts of interest.
I don't have any conflicts of interest. I am going to shout out to one of my colleagues, Katie Penrose, who did an excellent presentation on the update in the cervical screening guidelines, and I have drawn from that strongly for this episode.
And so this is a research interest of mine, but nothing is commercial in my research interests.
Thank you. Anna, can you start us off with an overview of the new cervical screening signposting clinical guideline? What has it replaced and why has college chosen this particular approach?
I think there's a few guidelines that we've used the signposting approach for. When we know that there are really good resources out there, there's no point us just replicating other people's work. So this has replaced vaginal screening after hysterectomy in Australia, vaginal screening after hysterectomy in New Zealand, and a screening for DES. And now just signposts to the two national screening programs. So that's the Australian National Cervical Screening Program guidelines and the Te Whatuora Cervical Screening Clinical Guidelines in Aotearoa, New Zealand. Both of those guidelines are evidence-based. They use the AGREE tool. The Australian guidelines are hosted on the Magic app. So it just means that it's going to be a living resource. It's updated with new evidence when it's available.
And from your point of view, Jared, how does this model support clinicians, particularly those in rural or remote Australia?
I think the newfound guidelines are absolutely fantastic. They actually come in many different formats, including what Anna's spoken about as the online. There's flow charts, there's summaries. I had them all downloaded on my iPad, so internet or no internet, I've got access to them at all the time. And I think it's a really good that they're clear, they're evidence-based, and wherever a patient may be, if they go between a health service, between a state, we're all following the same guidelines and we know where they are on that treatment pathway. It really cuts through a lot of the noise. This is a set thing that we should be processing and we can all use them together.
Makes such a difference when we are all doing the same thing across the country. It makes it easier for us. It makes it easier for patients.
Absolutely.
Anna, let's take a moment to talk about HPV screening. It's one of the most significant developments in cervical screening in recent years. Can you explain to us why this shift is so important and what it means for clinical practice?
HPV became the primary screening tool in Australia in 2017. Also the move at the same time to 5-yearly screening if you've got a negative screen, because we know that HPV is what causes cervical cancer. For women who have HPV negativity, they are reassured that that result is accurate and makes them very low risk for the next 5 years. The big change that happened in 2022 is the option for all women to self-collect, and that's been a huge step forward. Now, I think it is important to remember it's an option, so women can choose to self-collect, and the downside of that is if they test as HPV non-16 or 18 positive, they will have to come back for a clinician collect to get cytology, because you can only do an HPV test on a self-collect. But for a lot of women, the speculum examination was a barrier to cervical screening. And so I think it's a really great initiative that occurred a few years ago. We can see there was a little bit of a slow uptake in the first couple of quarters after it was brought in, but since then there's been pretty much a doubling of the uptake of cervical screening with self-collects. And interestingly, that increase includes both women who are self-collect, but more women who are having clinician collected as well. So there's been a significant improvement in screening. And we're probably accessing women who are more important to access with that self-collect, because there's a higher rate of HPV positivity in self-collects compared to clinician collected. And it tends also to be women in rural and remote areas and women who are in lower socioeconomic groups who are self-collecting. So it's a really important change. And obviously the HPV program is the other part of that is HPV vaccination, and that's been around for a while. And since 2023, it's been a single dose of Gardasil 9, and there is actually a kind of free catch-up dose up until the age of 26. So for people who didn't get it at school, you can still get it for free with your GP up until 26, which is a great opportunity. And those two kind of approaches together, the vaccination and the HPV screening, aims to eliminate cervical cancer in Australia within the next 10 years.
That's so important, Anna. And, when you talk about that self-collect is an option, equally important to remember that for the women who want a clinician collect, that is still a good thing to do. And clinicians should be encouraging women to have that if that is acceptable to women.
Absolutely. I think it's important to have that informed discussion. Like, if you don't want to have the speculum, that's fine. You don't have to. But there is a small disadvantage that you might be called back and have to have a second appointment.
Jared, building on what Anna has just said, what does implementing HPV screen look like in rural and remote settings? What are some of the unique challenges you face, particularly in First Nations communities?
Absolutely. So the introduction of being able to do the self-testing has made a big difference. We've got the same benefits that all women have and people with cervix, is that there is the 5-year gap. And so people don't have to access the health service, because many of these communities, clinicians may only visit every sort of 3 or 4 months. So the opportunity for people to have the testing in between if it's sent away. And there's also the opportunity that in a lot of these communities, people know each other and they may not have felt comfortable to have a speculum examination with maybe who might be their relative if it's a small thing, or someone they know, and now they've got the opportunity to also have the self-testing. So we're also seeing a much higher uptake of cervical screening now that you have these new ways of doing it as well.
Which is so good to hear. We'll be back in a moment after this message from RANZCOG. The RANZCOG annual scientific meeting is back for 2025, and this year we're bringing it to Adelaide. Heather, what do you have in store for us?
Thanks, Nisha. We're really looking forward to hosting the RANZCOG ASM, and from the 18th to the 22nd of October, we would like everyone to join us at the Adelaide Convention and Exhibition Centre for 5 inspiring days of learning, insight and also real connection. This year's theme, From Conception to Curtain Call, reflects the full journey of women's health, with sessions covering fertility and pregnancy to menopause and beyond. You'll hear from the global leaders in the field, including Dr. Matthew Leonardi, Dr. Laura McGee and Dr. Linda Brubaker. Plus, we've got some excellent hands-on workshops planned, and don't miss the gala dinner. It's going to be a chance to network, dress up and unwind with colleagues. You can earn 23 CPD hours for attending the full program.
That sounds fabulous. I can't wait to join you in Adelaide.
For anyone who is wanting to join us, visit ranzcogasm.com.au and come visit us in Adelaide.
Looking forward to seeing you all there. Welcome back. Anna, how do the national guidelines support care for higher risk groups like immunocompromised individuals, those with a history of DES exposure?
So for people with a history of DES exposure in utero, that hasn't changed. So it's still annual co-test and colposcopy with a careful vaginoscopy at the same time indefinitely. There has been some clarification around immunocompromised individuals. Because they're a high-risk group, they are recommended for HPV screening 3 yearly rather than 5 yearly. And that's been for a few years now. But the newer guidelines just clarify the ones who are sort of higher risk. So that's women with significant immunocompromised, so women who are living with HIV, who've had a solid organ transplant and on immunosuppressants, with active hematological malignancy, stem cell recipients, and women with immunodeficiency. And then there's another group of women who are not recommended but should strongly consider 3-yearly rather than 5-yearly screening. And that's some immunosuppressive therapy, so high-dose steroids, some disease-modifying anti-rheumatoid drugs, so like methotrexate and mycophenolate, and biologics that target T cells. But there's not all the biologics, so it's not like infliximab or rituximab, like the anti-tumor necrosis factor alpha agents. No one's going to remember this list. I do not expect you to. I don't remember it. But like Jared said earlier, it's all on the guidelines and it's all laid out with the flowcharts and the text accompanying the flowcharts. So just I think it's useful to know that there are slightly different agents and there's slightly different categories, and you're probably going to have to look it up all the time.
That does make a lot of sense. And if it's easy to look up, why wouldn't you? Jared, the guidelines in both Australia and New Zealand emphasize the importance of trauma-informed care, particularly for people who are underscreened or who have had a difficult experience in the past. What does that actually look like in practice in the communities that you serve?
It's been very impressive to see that both in New Zealand and Australia, and I'd actually say that New Zealand is probably leading us with ways that they have looked to make sure in trauma-informed care and cultural safety has really been embedded in their guidelines right from the start. And hope we might get time to talk about some research that's happening in Australia today, but we've actually looked to New Zealand to guide our ways to make sure it's culturally safe. But it's really important that we also look at other groups besides our First Nations that may have to look at the way that we do cervical screening, such as people with cervixes that might have diverse genders, and also people from that have had female genital mutilation or cutting, that we do take this into consideration with the way that they're screened as well. And the self-testing might actually open up the opportunities for them to access it. I think that it's actually about slowing down, taking the time, as Anna's also spoken about, and giving options. Because if you give women and people with cervixes options, then they feel like they're in control. And I think that it is very important, like we spoke about before, not just offering self-testing to everyone, because we think that would be easier, but actually asking them. And many of our people and Aboriginal women might have to travel 4 hours to get the testing, so they don't want to come back again in a couple of weeks' time, or a clinician might not be there for another few months, so they might actually want a clinician-collected sample as well. And I've also seen that making sure the patients are in control is what they feel comfortable with. And we've had a couple of episodes where people have taken self-testing and they think, a couple of weeks later, oh, maybe I didn't do that correctly, because they're quite nervous. We as clinicians and scientists know there's safety checks to make sure that a correct sample was done, but they didn't feel comfortable doing it as well. So I really think in putting the patient in the centre, getting their consent, giving them the information, and really following what they do as well. And the other one is who actually looks after their cervical screening. And this could be quite different for some women. They state that they would like to see a female clinician to see if we can actually offer that. Other times, when I've offered that, they're like, no, I know you and I feel more comfortable with you because I have a relationship. So sort of seeing what people would like to do about that as well, just to make sure that they're in control.
Now, managing inconsistent results across colposcopy, cytology, and histology can be really complex. Jared, how do the guidelines support clinicians through this? Can you share how this plays out in the real world where you might have been involved?
I'm very much lucky enough to perform colposcopies at probably about 5 or 6 different communities, and I have a database where I record all the colposcopy, and then a week later I sit down to have a look to see what the results came back of clinician collected samples and biopsies. And you always feel a little bit apprehensive, what happens if I thought the colposcopy was completely normal and we get an abnormal finding? So what do we actually do? But I think we're quite lucky now that the guidelines are really good to show us what we should do in these situations. And one example might be that you have undertaken a colposcopy. It's a type 1, type 2 transformation zone. It looks quite good, but the cytology does come back as possible high-grade changes. What do you actually do in this situation? But there are flow charts, which I really like in the guidelines, that sort of speaks about that you can do an MDT. And it's really important, I think, for us regional and remote people to be linked into a service that can give us a second opinions, and also speaking to the pathologist. They actually really love to speak to you and reread the slides and the biopsies. And sometimes it does actually change, they can make a difference to what you actually do with the patients. And so I find that that's really handy. And Anna's one of the experts that I quite often contact in her team to sort of get a second opinion. We are also seeing that if you do undertake a biopsy and it just comes back with CIN2 and the person may have not completed their family, that there is also opportunities now to monitor and sort of may not actually go straight to treatment as well. So we're seeing that actually that sometimes we've done for a little while, but it's actually now in the guidelines as well that we can take that into consideration.
It just goes to show that although we feel colposcopy is very much dependent on us as the clinicians performing the colposcopy, there's a whole multidisciplinary team who can help us in situations where things are not as clear. Anna, there are some specific groups with recommendations for what to do in the guidelines, say cervical screening in pregnancy, in young people, when to exit the screening program, what to do after a total hysterectomy. Do you want to make some comments about those?
Yes, gosh, that's quite a lot to cover. So thinking about pregnancy first, essentially it's the same as for non-pregnant people. You should have a routine cervical screening test if you're due in pregnancy or if you're overdue. And that's actually a great opportunity to reach out to underscreened populations. So that's both antenatally and postnatally. The options are the same. You can either have a self-collect or a clinician collect. And the only difference is that if you're doing a clinician collect, you wouldn't use the endobrusher. You wouldn't use something that goes up inside the cervical canal. The follow-up is the same for non-pregnant women. And if you're seeing a pregnant woman in colposcopy, it's important if the colposcopy is done by someone with some experience in that area, because the pregnant cervix does look a little bit different. Really, the aim in colposcopy and pregnancy is to rule out a malignancy. And if you think there is a malignancy, please refer straight on to gynae-oncology. Don't take a biopsy yourself. We don't biopsy in pregnancy. And we just need to reassure women that they're safe to continue their pregnancy, and we will then follow them up after birth. For women with high-grade changes and a type 1 or type 2 transformation zone, we would arrange colposcopy to 6 to 12 weeks after birth. For women with a type 3 transformation zone, you would repeat colposcopy and repeat cervical screening tests at 20 to 24 weeks of pregnancy, assuming you're seeing them early on, and then again at 6 to 12 weeks after birth. So it's just making sure that they feel safe and supported during their pregnancy journey. For young women, the screening program is not aimed at women under the age of 25. And the really only caveat to that is that at any age, if someone presents with possible symptoms of malignancy, so abnormal sort of bloody discharge or postcoital bleeding or intermenstrual bleeding, and you've ruled out STI as a cause for that, then they should have a co-test. So that's a speculum examination and a co-test, and that's irrespective of their age. Otherwise, even for women who had their first episode of sexual intercourse before the age of 14, assuming that they had the Gardasil injection prior to that, cervical screening isn't recommended until the age of 25, although you can offer a single either self-collect or clinician collect at the age of 20 to 24. But even in that situation, it's not recommended, but it is an option. And when you're thinking about women at the other age of the screening, so women who are about to exit, so exit smears are done between 70 and 74, and a colposcopy should be offered for any type of high-risk HPV, so either HPV 16-18 or the non-HPV 16-18, if you're showing HPV in that age group. Women over 75 can request a cervical screening test if they haven't had one in the last 5 years. And the short course of topical estrogen can make that examination more comfortable and also can give you a slightly more accurate result. And then the last thing you asked me about was post-hysterectomy. So for women who've had normal screening program previously, or who have had high-grade changes but completed their test of cure, and on their pathology specimen from the hysterectomy, the cervix looks normal, that's easy. They have no further tests, so that's straightforward. If women have been underscreened or have had low-grade changes or high-grade changes at surgery, then it's annual HPV test until there are 2 negatives. And if there are glandular changes or they've had a history of AIS, then it's annual co-test until there are 2 negative. Again, I think, like I said previously, some of these things are a little bit trickier. So if it's the more complex area, the flowcharts are there.
Jared, another common question that comes up in practice is whether cervical screening is still necessary for women who aren't currently sexually active. What do the national guidelines say in this situation?
Absolutely. This is a question we get asked quite often, and also something that goes with it, that if you're HPV negative and you're in a monogamous or closed relationship, do you need to continue cervical screening? And we have some research now around this coming out of the UK that HPV can actually become dormant. And while it's dormant, it doesn't cause problems, but it also can't be detected on the HPV testing. So it is sort of, if anyone has had any sexual activity in their lifetime, that they need to continue the screening up until, as Anna's just spoken spoken about the way that you can actually exit the program. And also, we do know that we need to educate patients that things like condoms doesn't always actually stop HPV being transferred. So even if it was sort of barrier protected contraception, we still need to do HPV testing up until the 75 and exit of the program.
But what about someone who's never been sexually active at all?
So the Australian guidelines for never been sexually active states that they don't actually need to undertake the cervical screening. Just to let our listeners know, that is different to some other countries, but in Australia, you do not need to enter the program.
That's good to know. There are some other changes in the guidelines around test of cure, Anna. Can you talk us through those?
So women who've had excision of high-grade changes, previously the test of the cure was annual co-tests until there were 2 negative, so that's negative for HPV and negative for cytology. But now that's moved to annual HPV screening. Unless you've got 2 negative HPV screens, then you go back onto routine screening. For women who've had AIS or glandular changes excised and they've had clear margins, and if they haven't had clear margins, then they need a re-excision until they've got clear margins. But if they've had clear margins, it's annual co-tests for 5 years. And assuming that they are all negative, so that's both cytology and HPV negative, they then go to 3 yearly co-tests. And after 25 years, they then go back onto the routine screening. And by that time, the routine screening, they may have exited the screening program for age reasons. Towards the end of the screening program for women who've had AIS excised, it is again a little bit more complicated. So it's 5 negative annual co-tests. And then if they're over 75, they can exit the screening program. But if they're 70 to 74, they then have one of the 3 yearly ones, and then they can exit the screening program.
What I'm hearing is that there's lots of complexity, but that this is all much easier to do if we just refer to the guideline itself, because it's all in there. Yeah. And so we're not expecting anyone to listen to us and remember everything that we're talking about, because that would be very difficult to do.
Yes, I think it's useful to remember that the HPV, like the test of cure follow-up, is now HPV only. Because, again, for women who really don't like speculum examinations, the fact they can do it as a self-collect is a big bonus.
What about the role of consumer resources in this situation? Where can clinicians find them? How can they use them?
So both Australia and Aotearoa New Zealand have accessible resources in multiple languages that can be available to consumers. You can download them, or you can ask to have them posted out to your practice and provide them for people to read before they come or at the time of their appointment.
Do they also have video-based resources, or are they all sort of written and resources to be read?
Yeah, there are excellent video resources available
online. Which is really useful, because not everyone is as literate, I guess, in various languages. I know certainly that women speak languages but don't actually read the script of that language. So having a video that's easy to follow is helpful.
Yes, and also I guess a lot of younger women prefer video resources.
Of course.
I'm thinking about my teenage daughter and TikTok.
And there's definitely for our First Nations specific resources as well, which is great to link into.
Jared, what's next in cervical screening? What should we be preparing for?
It's so exciting that Australia is going to be potentially one of the countries that's going to eliminate cervical cancer. So there's so much happening, and I'm looking forward to being part of it, as hopefully everyone as well. I think the first thing is just getting the message out to women and people with cervixes. And I was very excited that we came here to the recording studio today. I saw a poster on the bus, advertising different ways to do cervical screening, and then heard an advertisement on the radio in the Uber. So that was fantastic that messages are actually getting out, that people will know that there's more than one way to cervical screen these days, and so we'll actually have a conversation with their clinician. We're also seeing ways to actually let people know about cervical screening is due for them, so using digital electronic records, because we do know, unfortunately, that a lot of cervical screening, or the majority of it actually, is found in people who are under or never screened, so reminding people when it's due. And then we've got some really exciting things about moving on to the next step. So at the moment, cervical screening is very important, but if we do find a positive result, are we actually having people access colposcopy and then treatment as well? And this is an area in particular that I have undertaken some research with. And we have the PREVENT study, which hopefully we'll have in the links today, but has been published in the Lancet Public Health this week, that looks at offering a one-stop shop. So women, mostly Aboriginal women in the remote communities of the Kimberley, were able to come in and undertake a self-testing, and then we ran it through a point-of-care machine, and we're able to get a result about 45 minutes later. And then if they had a HPV positive result, so we did include non-16, non-18 because we didn't have access to cytology, they were then able to have a colposcopy at the time. And the uptake was fantastic. So we had, in a very under-screened population, we had over 35% 50% of these people come out for the first time to have cervical screening. And a lovely part, we were packing up the machine at the airport to take it to the next community, and people were still coming up asking because mothers had told daughters, daughters had told mothers. So it was a Aboriginal controlled research project that showed this was a really good way of actually showing ways that you can do cervical screening out in the communities. There's also some things happening within RANZCOG, so we want to try and access colposcopy, so have a GP colposcopy program that I hopefully is going to be released soon. So GPs will be able to become certified and undertake training to do colposcopy. And we're also seeing that AI is becoming involved, as it is with everything, that it is able to assist with colposcopy to talk about what areas we could biopsy and give us a little bit more information. And it may mean that we don't actually have to have a trained person holding the camera, but we could have someone that can use the AI as well. I'm also hoping that there's going to be some new treatments come out, because we do know that people are worried about the risks of LETs and cones on preterm birth, and we do know that families, unfortunately, they're not complete when they do need treatment, and if we have some new treatments available, people might be happier to have that as well. And I think the vaccinations as well, more subtypes are being included that we can eliminate cervical cancer. So lots happening in that area.
The one-stop shop certainly sounds like a really good way of doing cervical screening and would be equally applicable in the cities, where women then don't have to have that additional stress of waiting for weeks before they get a result and then waiting for weeks after that to have their colposcopy. So certainly something we in the city can learn from the research you've done in rural Australia.
Absolutely. And we know that some of our colleagues are trying this in the Pacific Island as well, and the government is going to roll it out as an option very shortly.
One final question for both of you. What's the key message you'd like our listeners to take from the updated guideline? And I'll start with you.
I think, as I've mentioned several times, it's really as having that as a shortcut on your browser, so you can just look at the guidelines when you need them, look at those flowcharts, and then just discussing with women the options of self-collect versus clinician collect and the option that's right for them.
Jared, what about you?
I would say it's access, and this is what the guidelines are looking at, to make sure that people have those options, because if we don't have people able to access and feel comfortable, we're never going to eradicate cervical cancer.
Thanks, both of you, for your great insights. And as Anna and Jared have both said, look up the guideline when you need to and make sure you have a clear discussion with your patient who is in front of you, and follow the principles of shared decision making. You can read the full cervical cancer screening in Australia and Aotearoa, New Zealand, a signposting clinical guideline, on the RANZCOG website. We've included the link in the show notes. If you enjoyed this episode, please rate, review, and subscribe and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more essential conversations on Talking ONG.